Thank you. I hope you're all awake after lunch, so I don't bore you too much for half an hour about depots. I guess some of you might have thought initially that it's a bit of a conundrum having the title and the focus. The title and the focus of the conference about sort of improving patient care, and the title of my talk is about depots. I don't know if you're on the side that thinks that's a bit of a conundrum and they're not consistent. Just as a reminder that we have a range of depots. I'm not going to speak in detail about pharmacology, and I'm not going to speak in detail about any of the drugs in specific detail either, in case that's any encouragement to you. I guess what comes to mind for you when you think about depots? What are the sorts of things that you think about as a member of staff? I don't know whether you think they're a good idea, they're good because they ensure people get the medicines, or whether you're more on that side that thinks, how can she talk about depots and improving patient compliance and patient care? There were just a few of things that came to mind when I started to prepare and began to think about depots. And that's us as professionals. But I wonder what patients really think about depots. Is it more that we are doing something to them in terms of care, and it isn't really care, it's something that's forced, no choice, no option, and something that is not seen very positively at all. So I guess that's the two sides of the coins about depots and treatment care. Just may sound a bit straightforward, but before I go on what is a depot, I'm conscious not everyone in the room is a doctor or nurse, and we all have our own suppositions. Just to say depot, I guess we always mean an antipsychotic that's given usually as an oil in an injection every 2 to 4 weeks is broadly what we refer to, but it doesn't necessarily mean that. So outside of a mental health context, it just means a long-acting injection. Probably some of the women in the audience are well aware that you can get contraceptives as depots and other hormones as well available as depots. So just want to re-emphasise that I'm not just talking antipsychotics. It doesn't necessarily mean it's an oily injection, although the vast majority, as you know, of our current depot antipsychotics are oils when they're given as an injection, and it's intramuscular, and it's different to an implant, which is a sort of a physical lump, as it were, that is implanted into you and then has to be removed afterwards. So there's a difference between a depot and an implant. That sort of said and set the scene. These are, I'm sorry it's quite small, I'm trying to squeeze it all on the one slide. These are all the depot antipsychotics that we do have in the UK at the moment. And I don't know about you, but when I had to put that slide together and look up the exact dates of when they came out, that's just a bit of a reminder about when they very, very first came out. They're not new things, broadly speaking. Progressing down the list, there's been a more recent one, so Consta, I guess, was our more recent addition, but even that now is 8 years old, believe it or not. And then obviously there's the olanzapine depot, which came out this year, and then hopefully, well, it's assumed that there'll be a new one next year, paliperidone, which is the metabolite of risperidone. So there may be further developments next year with a new product coming online. But broadly, if you look at that list, they've been out, some of them, since the 60s, which is probably a lot longer than most of us have been practicing, but not everyone. Bit of background, in the UK, we're a bit of a user of depots, but the rates of depot use has declined over the last few years, probably in relation to the atypicals coming out. And I'm not sure if you remember, if you were practicing then, but when the NICE guidance on schizophrenia first came out, I think it was 2002, there was a real push and emphasis to be using atypicals, and how could we ever consider going on using these dirty old-fashioned typical drugs, and we should be offering everybody atypicals first line and always. And a real push and a big change in prescribing practice to use atypicals, and at that point they were only available as tablets. Therefore it's not surprising to see that we've got a bit of a change, a shift in practice away from the older drugs, which depots are all the kind of antipsychotics, towards the atypicals. And then for those of you who work in LSUs and prisons, then the use of depots is proportionally higher than in other settings, particularly in outpatient settings. And then, as I mentioned, us in the UK, we're a bit of heavy users of depots compared to other countries. Denmark and Sweden, don't know why, I'm not going to comment. They equally use lots of depots, but the States and France really do not use depots again. So that's just I can't explain that away, but there's clear sort of cultural and sort of country differences in how people practice and the thinking behind it and whether it's acceptable or not to be injecting people. A little bit closer to home. What do professionals think? You're a bunch of professionals. I wonder if this sort of chimes familiar with what you think. This is sort of data from 3 papers at the bottom there. Looking at the first column on the left is the results from the psychiatrists, and the ones on the right is the list from the CPNs. So it was a survey, 2 or 3 surveys that were done asking psychiatrists and CPNs generally what they think about depots. Is this good practice or not, and what do you think of it? And you can read the statistics for yourself there. But there's a high proportion of people, so psychiatrists on the left, CPNs on the right. Psychiatrists in particular thought at that time, 2003, depots are old-fashioned things, and nearly half thought they're stigmatising. Broadly, it was overall thought that they were less acceptable to patients and to their relatives. But there's a bit of disparity there between the views of the psychiatrists and CPNs on that acceptability to relatives, which is quite interesting. And obviously, CPNs clearly thought it was better monitoring for compliance. Well, that's obvious, isn't it? Because they're the ones administering the vast majority of the depots. So you'd know if somebody turns up for an appointment or not, and you know that you've given it. And then, interestingly, despite all that sort of negative opinion about it being old-fashioned and stigmatising, the thinking is then that it's much better for relapse prevention. Surely that's got to be what we're keenly interested in. And then, just as a comment, there were some of the sort of free text comments that were picked out from the surveys and the questions that were done, were that they're often associated with sort of quotes, bad patients. And again, I don't know how much that is affiliated with various practice in prisons and LSUs of using more depots. So is that where that sort of association comes from? Just from a different population has depots used more often, so is that how that's been transferred? It was unclear, but certainly from both the surveys, both within the psychiatrists and within the CPNs, there was a sort of feeling that depots were used on the patients who were bad patients, whatever bad was meant to mean. So a mixture of responses in those questions. So why, if there's quite sort of condemning opinions from prescribers and those who administer it, why do we bother doing it then if the general overall thought is it's not good? Obviously, the biggest reason is to promote and encourage compliance, whether it's deliberate people trying to avoid medicines, or whether it's unintentional for those who genuinely forget to take the tablets on a daily basis. And obviously, promoting compliance has a very close link to relapse prevention. There's always a couple of patients who genuinely prefer to have a depot rather than have to take tablets every day, and that's part of the patient choice. And then there's the interesting thing about our preferences. We're the ones who choose with the patient, or sometimes choose for the patient, their treatment, their care. So I expect of those of you who work with different teams, or have done as junior doctors, or do as nurses, but at different prescribers, you notice the different practices between different consultants. And they have different preferences, and different people like doing different things, and have tendencies of practicing in some ways. And there will always be some people who like to prescribe depots, so they do. And there's others who don't like prescribing different drugs, so they don't. So there's an interpretation of what our preferences are as prescribers and users. And then I suppose, more worryingly, is it more convenient to us to have patients on depots? You know they're turning up, you know they've had it, you don't have to fiddle around with a GP and giving tablets and checking that they're taking and rechecking that they're taking, and it's quite convenient to us as a service. So is that a motivation ever for us prescribing? Why not use depots? From negative side, I guess obviously the opposite, the corollary. We have some of us have negative opinions of depots, so then we don't prescribe them, as we mentioned before. And obviously you wouldn't want to prescribe depots to patients who are needle phobic, because that would be exceedingly cruel. Anybody read the NICE guidance? Came out a little while ago, the reviewed guidance on schizophrenia. I don't know if you remember or recall what that says about depots. Basically, it doesn't say a lot at all. Unlike the previous guidance on schizophrenia from NICE, which was quite specific and directive to us to use atypicals first, the revised one in 2009 was really quite open. which is probably a lot fairer, and told us to use medicines wisely, to use medicines in conjunction with the choice of the patient, and didn't dictate whether we should or shouldn't use atypicals or typicals or depots, and kind of left the question much more open, which is probably a lot fairer and fits probably better with the patient choice agenda. So there's no national guidance to tell us to or not to use depots. So where does that leave you? Kind of, why would you not use depots? Any ideas how many people are compliant? Have a think in your head. How many people do you think are compliant, or non-compliant rather, with medicines? In the general population and in the mental health population, actually, it's pretty much the same. You may think, or may have jumped to the conclusion that actually in mental health, compliance is more of an issue, people don't take their medicines properly. Actually, the data shows wherever you are, whatever population it is, whether it's your antihypertensives or whether it's your antipsychotics, compliance is equally poor amongst all. We're all humans, we all don't see the need to take medicines unless we can feel it's making a difference. So if it's analgesics, and the compliance rate is a bit higher because you can feel it when you don't take it, so people then take it. But broadly, compliance is pretty poor overall in mental health and otherwise, and the NICE guidance on compliance reckon it's roughly about 50%. It's a very broad ballpark. Just to give you an idea, it's as low as that. And that's being quite generous with the definition of compliance and taking medicines properly. So if you assume that at least half of your patients left to their own devices won't take medicines properly when they're well, mentally well, that's a fair assumption. So that's a good reason for thinking about it, isn't it? Because obviously depots have ensured compliance to some degree. You know the medicine's gone in when they've turned up for the appointment, assuming they turn up for the appointment. And then clearly that's tightly linked then to relapse prevention and lack of relapses. I'm sure you probably know the data better than I. There's loads and loads of data to show what happens when people relapse and the consequences of it. Relapse will lead to hospitalisation, possibly progressive brain tissue loss, possibly poorer outcomes in the longer term, further deterioration in their daily functioning overall. And we heard this morning lots about costs and cost pressures, and obviously having somebody in hospital costs a lot of money as well. So we need to do all that we can to keep patients well, because the more often they're unwell, the more unwell they will become. We want to try and improve their prognosis. So to me, that alone is quite a big argument for ensuring the medicines, if needed, really do get into the patient. And maybe the depot is one way to do that. I've touched on it before. What influences us? Well, what influences the prescribers here amongst you? There's always the issue of individuals prefer different things, their beliefs about side effects, whether they think one drug is terrible and causes lots of side effects, whether that's true or not. Things that influence will be the patient's acceptance. I've heard my friend is on, or I've heard my family member is on, and therefore I don't want it. That's going to influence the prescribing. The stigma, the level of nursing staff involvement, the genuine issue of depot clinics in the community are full up and no one else can come on to the clinic because there isn't enough staffing to administer any more depots. That's a reality. Sometimes there's external forces, so with your organisational trust says we're cutting depot clinics, no more, send them all to primary care, where there's service things around that, or trust saying you can't have X, Y and Z expensive drug, or you can have only so many of this kind of expensive drug. And then thinking more about junior doctors, sometimes there's a lack of familiarity or confidence through lack of familiarity with how to prescribe depots, what dose, which drug one to check. A number of times I've certainly had junior pharmacists saying, what's the difference? That they're all the same, these depots. How do you choose between them? Obviously Constant's a bit different, but depots are depots, aren't they? Thinking about the advantages of depots, I guess obviously we've talked about the effect on prognosis. The cost and the benefit rate, there's lots of studies that show that the cost to the benefit is definitely worth it in terms of giving depots. It's easier to predict relapse if somebody doesn't turn up, that you're going to know if they don't turn up that they haven't taken the medicines. You've got that warning. They didn't come on the date they were due. You chase them, you ask them to come to another appointment. At least you know when they started to stop complying with medicines, whereas when it's tablets, it's very easy in retrospect on admission to figure out they've been non-compliant for 6 months, but the trouble is you didn't know that at 5 months ago. And for the few patients where genuine overdose is a real risk with tablets, at least if they're on a depot, you have minimised that risk there. Obviously they can buy other tablets and they can use other routes, but again, sometimes that is a real concern for people who have a pattern of overdosing with their prescribed tablets. So there are some reasons to think about using it. How acceptable are they to patients? That's the question I guess we should be asking. I think a lot of it depends about how it's done. I certainly can think of staff and nurses who manage to put across the notion of the most horrible things in quite a pleasant way. The idea of having a depot or coming into hospital, some people have such a knack and a way of approaching a patient and putting it across that it's actually far more about them, their communication skills, their way of caring for a patient, almost than the thing they're talking about. So I think it certainly depends on the way that the person explains it to the patient. I spoke to a patient yesterday who says she hates having her depot now because the CPN doesn't talk to her. They're so busy, she's in and out, she doesn't get a conversation, she doesn't want to be on her depot anymore. That's not about the depot at all. That's about the process it's set up, about the way the clinic runs, about the busyness of staff and the way they talk to patients. You always hear the anecdotal tales from patients as well about, I don't want so-and-so to do my depot, I want so-and-so to give my depot because they're good and they don't hurt. So there's always the real issue is sort of the skill of the nurse administering it and the experience of the nurse doing it as well. And just, you know, patients do develop nodules. It isn't always easy to give a depot. Some patients are really, really thin and it's very difficult to administer into a small muscle mass. And that's a reality that's going to affect whether a patient likes it or not. So what do patients think? Again, this is taken from another paper that was a questionnaire to patients asking them what they thought about depots. The vast majority of sort of satisfaction studies asking patients what they think are positive. I guess there's obviously issues with that. You could say, well, the people who participated in satisfaction studies are the people who are motivated, who are in that frame of mind, so that's a biased cohort, and they are going to say they're happy because they answered the questionnaire, and the ones who aren't happy either have stepped out of their depot care and aren't having it anymore, or aren't well enough to answer the question. But it is an interesting find, because I think that slightly challenges the survey results I presented right at the beginning about the CPN's and the psychiatrist's opinion of it. The majority of people who are on the depot who like it, they feel that it's a safety net to protect them from relapse, and they find it easier than taking tablets. And that's feedback from them, which is what we should be listening to. What they don't like, obviously, is the painfulness of physically receiving the injection. So it's not exactly the drug, it's either having an injection or partly the technique of the person giving it. And obviously there's an issue about it being intrusive and potentially degrading, just having an injection. This data is a little bit older now, and just sort of to mention, obviously, that depends a lot, again, on how the nurse is giving it, how the clinic operates, what times of day it is, whether you're asked to completely remove your trousers or not. But some depots can now be given in the arm as well, so that's another thing to think about if we're looking to make things acceptable to patients. I think if we're going to prescribe any medicines, and obviously the focus of this is depots, if you're going to do it, we need to do it well. We need to do it the best possible way that we can. All depots aren't the same, there's differences between them. And for those of us who are prescribing or advising or prescribing, we should know the differences between them and use them accordingly. From the studies that are done, that are quite hard to tease out because the medicines last so long, so the studies need to be quite long, but from the studies that are there doesn't seem to be any massive advantage of any one depot or over another, and we should be selecting according to the patient's characteristics. I still quite often hear people asking me what is the maximum dose, what can I give? And just to emphasise, a lot of these medicines I showed you in the table at the beginning have been around for years and years. And so things about licensing and the maximum licence dose are quite old-fashioned. So the maximum dose in the VNF isn't necessarily the maximum dose that you want to use. I guess that's speaking to the converted, probably. And to emphasise that the treatment should be reviewed. It should be reviewed regularly. It isn't just assumed that once you put on it, you're on it and you're on it for life. I just wanted to raise the question about non-prescribing non-medical prescribing and think about tweaking the doses in the long term. If it's decided that somebody's put on a depot, is there a role for non-medical prescribing to pick that up and to be reviewing the patient in the future and to be thinking about tweaking the dose and bringing it down later, reviewing the side effects, measuring the side effects, treating the side effects? Something to consider. Obviously, if we're trying to use our medicines well, we could administer them well. So issues about how we're actually going to administer them and how to physically give them. And those who've got better techniques are usually the preferred nurses to give the injections, as I'm sure you know. If we're going to use depots, again, use them well in terms of what we do in terms of verbally talking with the patient about it, talking to them and telling them just as much information about the depot as you would if it was a tablet. We're a bit more in the areas I work, I certainly feel like we're a bit more practiced now, informing patients about the medicines, about giving them leaflets, about telling them about the medicines. But I feel like we kind of do that with the tablets. I'm not convinced we do that as well with depots, but there's no reason there should be a disparity at all. We should be giving them an informed choice about, do you want this every 2 weeks, or would you prefer it every 3 weeks or 4 weeks? They're all things that we can consider. There's things we can consider about who should administer it or where it should be administered, at home or the GP surgery or coming into the clinic. About monitoring side effects. I'll come on to that in a moment. Hopefully some of you have heard of POMH. This is some data taken straight from their recent trials. So POMH is the National Organisation standing for the Prescribing Observatory in Mental Health. So this is a recent national audit that was taken out. You can see it was done twice. There's a baseline audit and a re-audit there, and you can see it's quite a big sample. It's 5,000 patients roughly in each. And it was an audit of notes, so obviously there's issues with auditing notes, things might have been done and not written, but that's the level of data that's collected. Audit of notes to ask, in people who attend for depots, was any data written in the notes about monitoring side effects? And as you can see in the top line there was no evidence of anything written in the notes in over a third of patients. No wonder people don't like depots if we're not even asking them if they're getting any side effects. And half of them, there was a general statement regarding side effects. And in a tiny minority, 12% or 17%, there was actually a rating scale done. So some places are operating well, some places are asking people and actually getting a rating scale done. But other places aren't asking at all, which doesn't seem very fair on the patient. We're not really investigating their toleration of medicine. And again, this was a similar audit by POMH, looking at the different depots. They're all named there, so you can see if there's a difference between each drug that's used, whether you think we monitor, say, Consta and your drug better than we review some of the other drugs. But generally, again, a sample of 5,000 and broadly looking specifically at EPS, which is the obvious side effect you'd want to be looking out for with most of the depots. We're not very good at actually asking if there's anything there. So ranging from top to bottom, 66, 73, 62, 68, 66, 57%. No evidence of any screening about EPS. So we're probably not doing our patients any favours there. Last one from the POMH set of data again, so 5,000 patients. And other things, did we look at BMI, did we look at weight, and obviously sexual side effects, because the vast majority of depots will affect prolactin, which will then have that alone or can have sexual side effects. And again, we're not very good at asking for that. So I looked at some of the advantages of depots, disadvantages of depots. Obviously, if patients are naive to medicines, then we don't really want to be using a depot that's going to last for a month. If we don't know whether they can tolerate antipsychotics or not. And we don't know whether they tolerate the actual formulation, the injection itself, so we should be using a test dose. The obvious effect of EPS and using that long term and whether that develops into tardive dyskinesia is clearly a big disadvantage of depots. But it isn't the formulation of depots, that's just using a medicine or schizophrenia itself. So we need to sort of separate out our awareness that TD may not be about depots, it's more about the drug. Maybe a disadvantage is because it's perceived as being forced, as I said right at the very beginning, something that's done to patients, that's no choice. That's rather ignominious, that's awkward or embarrassing. You find sometimes, again, just operational things that prohibit it happening. We want to transfer as far as possible people back to independent living, back to primary care, back to GP care. But some GP surgeries refuse to give depots. we're not always very good at reviewing depot doses or side effects as we just looked at. And it takes longer, doesn't it, to manipulate depots, to review the doses, to wait for it to kick in and to go to optimal effect. Certainly can take a number of weeks. And some of the depots, particularly Consta, are definitely not very useful when someone's really, really acutely unwell, because they're not going to kick in for a good few weeks. And if you want someone treated today, then clearly depot is not the way forward. I kind of put this as depot and oral conundrum, because I always find it's a bit of a conundrum, because obviously we as pharmacists go on all the time at saying monotherapy, use one drug, just use one antipsychotic. And obviously if you're trying to use a depot to address non-compliance, the whole point is they're not swallowing tablets properly, so you give it as an injection. So how does that then fit with using a bit of oral as well? But it does happen, and we can all think of times when we've seen it or done it, and it does make sense for that individual patient. But it does still sort of leave us in a quandary between not fully being able to do what we want to do versus not fully being able to do the reverse. So we're kind of limited by using the depots because they've obviously got side effects such as EPS, so we try and minimise that dose, and then we're often topping up with atypicals that don't cause EPS. So it kind of feels both ways, but maybe there's room for some of the newer depots, and as I mentioned right at the very beginning, there's yet more depots coming out in the future, so things probably will change. Again, I won't go through this now because I'm conscious of time, but again, there were nationally, certainly it shows from more POMH data that depots are used in conjunction with orals, which, as I said, is a bit of a conundrum. I can see how we always get there. I've seen it myself, I've advocated it on occasions myself, but it is a bit of a conundrum, isn't it? Ideally, we'd like to have a drug that is totally acceptable as a depot, rather than having to use a minimal dose and top it up with a more acceptable drug. This was done in a neighbouring trust a few years ago. There was a study about incentivising patients to have depots. I don't know what you think about that. But it is a tactic that is fully employed in the world of substance misuse. The NTA and NICE for substance misuse fully endorse incentivising patients to attend for their substance replacement in substance misuse, and they're given vouchers and things to use, food vouchers, etc., when they turn up to receive methadone and things. So it's just raising it as a question as whether it is ethical and to think about doing it in mental health, but if it is in substance misuse, then it raises the question about whether we should, with patients who are on depots who need a reason to turn up to have a horrible injection from a clinic. I'm not necessarily saying it's the way forward. And I guess I'm also wondering about the impact of CTOs, whether that'll change the way we practice in prescribing depots. Because you can definitely say and recall someone if you know they're not complying with treatment, and you know that for sure when someone's on a depot because they don't attend an appointment. So I wonder whether that'll change our practice. So in conclusion then, depot, just to sort of reiterate, depot is just the route of administration. Don't hear depot as definitely and always meaning dirty old atypical drugs used at high doses. Depot, the goal is to make sure that our patients are kept well, that we stop them from relapsing as best we can, and if that means using a depot to make sure that medicine really is getting into them, and if we're monitoring it and using it safely and wisely and reviewing their side effects, that's surely what we've got to aim for, to use the depots well. And to, alongside that, make sure that we're still maintaining patient choice in the same way that you would do if they're on oral tablets. And last question to kind of leave you with, are we reflecting our own biases in the way that we draw up patients' care plans? As I said earlier on, I certainly can think of prescribers who hate depots and never use them. I can think of other prescribers who love them and always use them. And I'm not sure if that's always fair. And that's all. Any questions?